My name's Mark Sishan. I'm Medical Director for Loyola's EMS. All the medical directors for Region 8 at our last meeting, we feel it's important that we get out in front of you as frequently as we can. Because of the size of our geographic distribution of providers, this becomes very difficult. So we're going to try something new. And what we're trying now is to get out in front of you, in front of the presentations for continuing education via iPod, iPad, or some type of video recording. Since I'm the first up, I'd like to welcome you all to this. I always look forward to meeting providers in our region as well as our systems. We're going to talk a little bit today about the art of intubation, the art of airway management. That being said, what are the concerns when you cannot intubate but you can ventilate, or if you cannot ventilate and you cannot oxygenate? And we're going to look a little bit at this from a common sense airway. Crash airway, when you need to immediately intubate or ventilate. Obviously, if the patient is alert, responds to pain, responds to or is unresponsive, has a poor Glasgow Coma scale, if any of these issues are concerning to you, then you need to look at how the patient is clinically as well. So in the circumstances where the APVU, they're either responsive to pain or unresponsive with the Glasgow less than 9, if this is not the case, then typically we can probably monitor these patients, unless of course you put the pulse ox on and you find that they're not saturating, and you need to consider a bag valve mask, supporting that airway, and then possibly even going to intubation. What if upon arrival the patient has poor responses to either painful or unresponsive with the Glasgow less than 9? Here again, if they're not saturating and you're not able to maintain oxygenation, there is going to be the need to intubate. Intubation, you should maximize your opportunity for success the very first time. And what I mean by that is get all your equipment set up. ET tube with stylet, suction available. What are you going to do and what is going to be your threshold for moving to the next step? What else do you have up your sleeve? Whether it's a rescue airway, an alternate airway, I refer to them obviously as having something up my sleeve, plan B, for when the intubation doesn't go well. That is extremely important. We have King Airways available in our region. We have the combi tube available in our region. And also everybody has bag valve mask capabilities in our region as well. What about a neonate? I know the CE involves a lot with neonates and delivery. Once the head is out, key thing to keep in mind is suction. Remember, as the baby's thoracic cage is going through the vaginal vault and being delivered, there's compression of the lungs, and it's a great opportunity then before the remainder of the body gets delivered to get that mouth and nose suctioned out. Always remember they're obligate nasal breathers. So if you're going to suction something, get the mouth suction and then the nose. Get that nose suctioned out. Because once that baby comes in, they're going to take a gasp of air, and if there's secretions in there, you don't want that child to aspirate any of that. Now, the other thing that we talk about a little bit is primary apnea versus secondary apnea. Primary apnea means that that child is not breathing initially. Remember, dry them, warm them, position them to maximize air coming in, and stimulate them. In the process of warming them up is a great opportunity to stimulate that child and get them breathing. If they're not breathing, then we need to move to a very rare circumstance, but something to consider is bag valve mask. Get some oxygen into the child. Children don't have primary cardiac issues, they have primary respiratory issues. So supporting that airway becomes extremely important in the resuscitation and subsequent successful resuscitation of that child. What about the meconium? Oh my God. Yeah. These are children when they're born. Meconium, again, is fecal material. It's going to be the thick kind of pea soup as opposed to clear amniotic fluid. Here again, the consideration needs to take place if we need to intubate this child. And that determination is just how vigorous that child is. What do I mean by vigorous? Are they crying? Are they a good cry, a strong cry? Are they active? Are they moving their arms and legs? If they are, then there is no need to intubate that child at that point. If they are not vigorous, meaning they're gasping or grunting, they're trying to get some air into them, they're flaccid in their arms and legs, they may be central cyanosis, that child needs to have that airway supported. And the best way to do that is to get them intubated and get secretions out. You may run into secretions in the process of intubating, so make sure you have what you need to be successful. Maximize your opportunity for success. Neonatal page 3, bag valve mask. How do we bag a child? Squeeze, release, and release. Squeeze, release, and release. You don't want to hyperventilate them too much. You want to allow for slight movement, breath sounds if there's someone that can listen while you are concentrating on maintaining that airway, if someone else can listen. If there's no chest rise in that child, make sure your mask is adjusted. The question comes up, what if they are a preemie? What if the mask we have that you carry in the ambulance is just too big for that child? There's a couple things that's more along the lines of MacGyver medicine, but pinching some of that mask to make it fit better on the face, on the mouth and nose, reposition that airway, suction the mouth and then the nose, open the mouth, use a little bit more pressure, but again, be extremely careful. And you're looking for chest movement, and consider the alternate airway in that child as well. Collectively, the medical directors are very proud of the work that all our providers are doing. We cannot stress that enough. You do a job day in and day out that is undifferentiated in patient care. We never know what's going to be coming across on your calls. We support your efforts. We wish by having these opportunities to talk to you directly that we can stress some of the things we feel are very important within our CE programs. So until next time, hey, be careful out there.